So today we are demonstrating a case of RCA CTO PCI in a patient with renal failure with as minimal contrast as possible, mostly either zero or ultra low volume contrast based on the need during the PCI. So as this patient angiogram was done, I think in September last year, before his pacemaker. I come to epicaudal. So we went through entire angiogram and analyzed. So he had only RCA CTO. There is a moderate disease or intermediate disease in proximal LAD. So what I wanted to do first is I want to basically assess LAD by IVUS. Okay. So we void LAD. So we'll do an IVUS from LAD just to understand how it is. And if MLAs are good, and we also assess LMCA. If MLAs are more than 4 mm square, I think we are not going to do anything to LAD. If MLAs are going to be less than 2 or 2.2 mm square, probably we have to even decide, whether something needs to be done for LAD. Okay, so we are doing IVUS from LAD. Done. Okay, image please. I'm recording. Epicranial, epicranial please. So I want to locate even septum. So it's pristine artery, so there is nothing. You can see, the small clot. It's okay. So this is the location of septal, which we recorded, and so that's where we'll enter into septal, and then we'll take retrograde wiring. I think, see, MLAs are quite good. So, okay, sister, give me 150 caravel with a tan blue wire. Done. Out. So this is IVUS analysis. You can see this is okay. MLAs are around 5.4. I mean, yeah. Next B3. So I think this is 3 with a block area of 50%, but there is not much of disease also there. So it's a vessel itself is small. You can show me the B2. You can compare it with the distal reference. So this is distal reference, which is 3.4. So overall, it is equivalent to the distal reference. So the thing is, there is no need to do anything to LAD as such. We are going ahead with retrograde wiring. Please send the wire. Send the wire. Push the wire. So what we'll do is send the wire. Send. Okay. So what we'll do is we'll try directly to go retrograde and put a wire at distal cap, and which acts as a marker for my antegrade wiring. So that normally when we do antegrade wire escalation, we keep giving contrast from retrograde, to make sure or to direct our wire into the distal vessel. So if you put a wire, pull the wire back. If you put a wire, at the distal cap, pull further. So that wire acts as a guide for my antegrade wire escalation. That is principally the reason why I want to put a retrograde wire first and then start antegrade wiring. We have also marked location of septal. This is the location of septal in IVUS. In allocranial, it just appeared towards okay. towards the left of the. Okay, so I think this bend is not sufficient. Okay, go to epicranial, please. Talker, please. Okay, so I entered septal. So that's fine. So, and in fact, that's the location of septal in, IVUS also. You can see there, right? Right. Come to RO, please. So it always makes sense, to give a little contrast to, mark your collaterals, septal collaterals, because this is going to play a crucial role in, collateral wiring. Oh, right. I think I'll go a little up. Yes. This is a good connection. All right. Give me sand, please. So what I'm doing, I gave 2 injections. Now what I'm doing is I'm cranial, please. Yeah, I'm only injecting normal saline just to flush off, the previous contrast, so that won't hold wire, and that also helps me in understanding, the another view. Okay. So now we have to plan, which collateral we have to take. I think that distal connection is good, right? Yeah, I think that's okay. And, yeah, I made a 1 mm band on the wire. So what we'll do is first we'll explore, the distalmost septal branch, which looks quite well connected. So this is what I thought of trying first, and yeah, it's completely following the course. Okay, just let me take some support with caravel. Oh. Okay, this has a limitation. So that first branch is not going, so we'll try to solve. Presence of multiple septals is, a problem to cross septal. This I have to go like this, not going. Right. Okay. So this is a septal we wanted to try, and which was quite well visible. Give me the sand blue now. Okay. Sand, sorry. Cyan, please. So we entered our desired septal. Now we'll check our luck. Okay. Keep a CO03 is also ready, please. There is a bend there. Keep CO03, please. Hmm. Okay. Okay, record. So at this juncture, I think we crossed subtle. See, this is a desired subtle which we wanted to enter. So we entered with sand blue and then we shifted to cyan, and this is a cyan wire. The bend was a bit significant. I think it took some time. But anyway, we'll see LAO. Always we have to confirm in two views. Go to LAO, please. Yeah. So now, yes. So this looks, it is in RCA. Yeah. Now I'm pushing. You can see, how the wire is going. So yes. Now I reached distal cap. So what I'll do is come to RAO. I'm not going to say keep AL ready, L.75 ready. So I'm not going to advance microcatheter right now. So I'll just try. Okay. I think it's just going easily. Okay. Then I'll advance. Okay. My original plan was not to advance microcatheter as it is going easily. So I'm just advancing microcatheter now. Yeah, give me L, please. So this is Caravel. You can see how easily it is going. So now what we are going to do is basically, I'm going to just knuckle this wire at distal cap. I want to knuckle this wire at distal cap and then, do antegrade wiring. Okay. I think, yeah, that was a plan. Okay. Let us leave the wire there. Okay. Give me guide. So we are now engaging, right coronary artery with the AL. Just come to RO, please. So always take this guide without disturbing, you know, left guide. Yes, yes. Now this one, this is the left guide. Okay. RO is a better view, to send the L down. Go, go. Hello, please. Yeah, give me 130 centimeters Corsair with workhorse wire, fan blue. Corsair 130, లేకపోతే fine cross 130 and sand blue wire and then Gaia 2 wire. So this is AL 0.75. You can just see. But I think it's not supporting nicely. Okay. Okay. Need a good support, huh? Give me talker. Give me Gaia 2, please. Yeah, give me Gaia 2, please. So we can see there is some calcium there, and it looks this retrograde wire is already into the CTO, and overall, the segment I have to cross looks, very short segment. The only concern here is my guide support. Yeah, let us see how. Yeah, I may have to switch to AL1 if it doesn't work. Please give me talker. Now what I'll do, It's a marker wire technique. We'll use our retrograde wire as a marker and do antegrade wire escalation. So principally what we are doing here is we are using retrograde wire as retrograde injection. So that's how you can reduce your contrast usage. Yeah, I can see here my guide is not at all supportive. Make a single mic, please. I think the tip is deflecting at the calcium. So I'll just try to push retrograde wire a little bit. Yeah, and we'll give a simple knuckle, so which gives me a 3 millimeters of diameter, to target. Yeah, I think I need okay. Gayatri or Conquest Pro Ready Petunjan. I think my guide support is poor, so this is Gaia 2. Yeah, there is some progress. Okay. Yeah, you can see I am just directing. Oh, so this wire is, I don't want wire to go into side branch. Okay. I want a wire loop here. Yeah. Okay. So we can see now it is within the loop. Come to our RO, please. So again, just reloop wire and see. Yes. Yeah. Almost looks within the loop. Yeah, just sweep from RO to LAO. Sweep from LAO to RAO. So we are just trying to see, how well the wires are approximated in both the views. So it is very well approximated. Just let me review the recording. You see both the wires are well approximated. Yeah. Okay, right. Okay. And we can as well see it is the tip of the wire is moving quite freely here. Tip of the Gaia 2 wire is moving quite freely. This record. We can as well do a slide test. I'm just doing a slide test. Oh, I think guide is not supportive for slide test. Okay, just go to LAO, please. So we can also inject, couple of ml from our retrograde microcatheter to make sure we are, I think, to make sure we are there or not. I think for me it appears we are there. Okay. Yeah. Okay. Just record this. Yeah. Yeah. Now you take again LEO to REO. Yeah. Come. We can see the wire is within the loop. Yes. Yeah. Except in steep LEO. But I think that's fine. Go to LEO. So most of the places, wire is within the loop. Okay. Or within the knuckle I created. So I'll just try to, we can give a little bit injection. Give me a 2 cc Leorlock, please. Yeah, pull this wire out. Because make sure, before advancing this wire further. RO. Okay. No. In this view, it appears nice. Okay. I think. Okay. Just go to LEO. So it looks okay for me, but I want to do some little buck. Yeah. And direct it medially and push. Oh, right. Mm. Yeah. Okay. Record. Come to RAO. Just check in two views. Yeah. So it looks perfect in both of you. The only problem is, guide is not supportive here. I think we need a guideline or two. Keep it ready. Okay. So once we are in distal true lumen, it's only, don't push the wire. It's only keep rotating, it will take the chords and, it will go. Okay, go to LO, please. I'm trying to advance microcatheter, but it's not getting advanced. So what I'm doing, I'm just sending my Gaia as far as possible with the rotatory movement, and then let me okay. Okay. Might give me guideliner and then 1 mm balloon collar. That's all calcified. That's the whole problem. 1.5 inches. So you can see this guide is too bad. Anyway, I'll just take it a little deeper for support. Okay, just show me RAO. So it looks quite okay. You know, the wire movement is quite, yeah, I'm quite comfortable, I think. Okay, yeah, first trapper balloon. Yeah, go to LO, please. So you can also see, you know, both wire and microcatheter are overlapping in almost all the area. So if wire goes deeper, it will support us well for further device advancement. That's what I'm looking at. But I think, okay, trapper 2.5 N, please. No, no, no. That never happens in such a big request. So I'm coming back with my Antegrade fine cross. What I'll do is I'll take a guide liner and then, you know, we'll take a 1 mm balloon and then we'll try to dilate the lesion. And then we'll advance microcatheter followed by, you know, IVUS and further procedure. So this is a 2.5 trapper balloon. So we are trapping antegrade wire. Yes, trap please. Yes. Yeah. Yes. Give me guideliner for 6 is better actually. 7 never use. Okay. Even any situation by default use only 6. The only thing is, you know, air embolism. But okay, we are not, anyway, we are not injecting, right? We are not really bothered about it. Yeah, give me 1 mm balloon, please. So we positioned guideliner into the RCA, but see, the lesion was definitely significant. So 7 French guideliner may not go down. We can do one thing, you know, we can also, yeah, I'll try to go with 1 mm balloon down. If it goes, it's fine. If it doesn't go, then we'll take a 2.5 balloon. We'll dilate proximal RCA and we'll deep dive with guideliner into RCA, and then we'll take, you know, further steps. Okay. I'm trying to go with guideliner. Yes, 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 yes. Okay. Guideliner got in. Yeah, please dilate. Please dilate. And keep another 1 mm balloon ready, please. Dilate. Yeah. 38. Yeah. Don't have retrograde Y. Give me retrograde Y. Yeah, negative. Okay. Dilate again. Hello, Naru. Fine. Negative. Yeah, dilate. Cyan blue or cyan? Okay. Negative. Okay. So I'm just marking my distal cap with retrograde wire. So that is where this balloon has to go. Negative, right? Dilate. Give me another balloon. Go 12. Do granuloplasty. Yeah, yeah, yeah. Okay, ruptured. Negative. So we did granuloplasty as this balloon is not going in. So we just ruptured it. Give me the next balloon. After this, I need a 2 balloon, please. Okay, so I think now we crossed. I think we almost went up to distal cap. Yeah, connect. You can see my retrograde wire loop is marking the distal cap. Dilate. And what's a nominal, please? Okay, okay, okay. That's fine. Negative. Dilate again. Negative. Dilate. Negative. Dilate. Negative. Dilate. Give me 2 mm balloon. Negative. Okay. Just give me a 2 balloon. Oh, now we can see how Gaia wire is going down so freely. Give us microcatheter. So, well, what we'll do is we'll just send microcatheter down, but the problem is we can't put a trapper here. See, generally in microcatheters, carefully we can send without even a trapper in. Okay, if it is Oxford, you will struck out. Yeah. So done. So give me the workhorse wire now. I think I need a bit support wire. So what we are doing, so we are just sending Antegrade microcatheter down. Now you can see, yeah, this is Antegrade microcatheter. So which is, yeah, which is just gone down into the distal vessel. Yes, give me wire. Give me that cyan blue wire. Okay. So I'm in P. Okay, yeah. So we exchanged wire. So with the dock extension, we are removing. See, once your guideliner is in, it's very difficult to put a trapper balloon. Okay, so this is very important. If you lose access, then you're going to lose everything, right? Yeah, give me balloon now, right? Come down. Yeah. So we are pre-dilating with a 2 mm balloon, and after that we'll take IVUS catheter in, and then we'll mark reference zones and sizes of the reference zones, and then we'll decide about our sending strategy. Yeah, dilate please. So don't remove retrograde wire because it also helps. Yeah, dilate 10, 12. So it also helps in yeah, dilate in positioning your stent. Negative. Yeah, dilate. Yes, give me IVUS, please. Yeah, image, please. So I think this is normal vessel. I'll just scan the. So I'll just scan the distal vessel. I think there is some block here also. There is some block here. So, but I think the vessel is completely negatively remodeled. You can see here. Yeah, this image from here. Okay. Yeah, image. So vessel is completely negatively remodeled. We can see. Yeah, I think. But there is a huge block here. Okay. And there is. This vessel is normal. I think this can be used as a distal marker. So I think throughout the cross is only true lumen cross. I think we are in CTO now. There is a good calcium which we have seen. That's what actually prevented, wire crossing easily. Yeah. I think we have to definitely dilate with a final sized balloon before you take stunt in. Okay. I think this is nice. Okay. Okay. We are dilating in two orthogonal views, just to 22. And this is a 2.5 balloon. Okay, done. Negative. Yeah, good. Yeah, dilate. So it expanded nicely. Okay. Good. Hello. Nice. Okay. Okay. I think with this dilate anyway, we have to include this also into something. Okay. Yeah, negative. Okay. Yeah. So this is the first IVUS which we have done. There is a block throughout, but this is, you can see it's a 3.7 mm square with a 47% plaque, B2. This is another area where plaque was there, but plaque area was around 53% and the lumen area is 3.3. Basically, it's a negatively remodeled vessel where plaque area looks bit, more. And once these vessels goes into positive remodeling after opening CTO, so lumen area increases and plaque area will come down by ratio. Yeah, B3, please. So yeah, this is the distal reference which I'm thinking nearly around 2.7, it's around 2.6. So we can take a 2.75 stunt also here. So B4, see, this is one area which we thought we should cover because block area looks a little significant. B5. So that's the reason we are thinking of, long stunt. But what normally happens is, now I dilated with a 2.5 vessel and we'll give a good NTZ and we'll see how the distal vessel is and then we'll decide on where to wear stunting. With this first IVUS, we thought, we have to stunt from B3 to B6. That is coming around 46 mm, which was not look like, at least in angiographic assessment. Yes, yes. Okay, so what I'm doing, I'm almost imaging from crux just to make sure entire vessel is fine. Okay, image please. Yes, so we are imaging from crux just to make sure because the distal vessels appeared well in retrograde injection, but from crux we couldn't see so well. You can see here there is only mild blocking, but overall the vessel is good. Yeah, here also there is mild blocking. Yeah, we'll see the lumen areas. How much is the lumen area? I think this looks a bit significant lesion here, but anyway. Yeah, here also, yeah, block looks significant, but there is only discrete block, very discrete block. I think this is a proximal landing. Okay, so just beyond. Okay, out. Show us the area at B7. B7 block area. So there is 60% block area. I think I have to cover this. At B6 also there is definitely there is some block area, but for me vessel also looks little negatively remodeled. So what we'll do is we'll just do a ballooning, maybe with a 2 mm balloon at that site, and see if it is looking better. We'll leave it. So we are taking 2.7548 to liberally cover, the second lesion. But third lesion, probably I'll just do a FOBA with a 2 mm balloon and, come out. Yes. Okay. Deploy, please. 12, 16, negative. So stunt is well expanded in LAO view. Now we'll just show you in RAO view whether it is expanded. Yeah, dilate, please. Yeah, so it's well expanded. Negative. Yeah, we can go say 2.75 NC proximally. I think we can go with a 3 or okay. Right. So we'll come out with this and then okay. Out 75 NC, please. So what's the distal reference at B8, please? Vamshi. Yeah, it's only 2 point. Yeah, so I think 2.75 is good size distally. I think proximally we will dilate with 3 after IVUS. We'll decide. Okay. Boost, please. Yeah, 14, 16. Okay, 18, negative. So we'll do an IVUS and see, how the stunt is expanded and how, the distal vessel is and the edges are and opposition is, and based on that we'll decide about, further dilatations. IVUS close, please. The card. Yeah, now we can see even distal vessel size is significantly increased, once we stunted. That's what generally happens. This area is also, which we dilated with a 2 mm balloon, we can see. Now, there is no dissection and the luminary looks good. Since there is negative remodeling, I'm hopeful, this area, we can leave it. Okay. Or we can just do a regulating balloon. So our distal landing is perfect. Good expansion, good opposition. So I think we can even dilate with a 3 balloon. So up from the lesion upward. Or in fact, we can even leave it. So I think, yeah, it looks perfect overall, right? And our landing zones are also perfect. Just give us a sense of, block areas in distillations and proximally, yeah, yeah. What's yes, yeah, bookmark, yeah. Okay, that's a good area. Next, come, wherever it is small, you put a bookmark, please. 2.7. Bookmark, please. Yeah, 3.2. Okay, done. Okay, I'm gonna give us a 2.25 balloon. Okay, first give me 3 balloon for proximally the size is quite good. I think I'm going with a 3 balloon for further dilatation. I need a stunt boost, please. Stunt boost or normal cine, please. Normal cine, please. Are you epicranial, brother? Okay, 22 negative. Okay, hello. Yeah, dilate. 20 negative. Yeah, just 6, 14, 14 negative. I think that's enough. 12, 12 negative, negative. Okay, so we dilated with a 3 balloon, right? So I think just give us a 2.25 balloon. So we'll just dilate, the distal lesion with the 2.25 balloon, and we'll leave it. See, we don't want to stunt it because there is also remodeling there, so which we don't want to stunt now. And also this patient, if he needs, if he plans some renal transplant subsequently, I don't want to leave a complete metal jacket RCA, which also makes sense. It's also a good idea, to put a regulating balloon in that area. Yeah. Pilot. 8. Okay, just keep 10. Okay. Okay. So we are just dilating that area just to give a good. Okay. And once RCA IVUS is done, so we'll show you the reference areas and stunt areas. Later we'll go to removal of retrograde microcatheter and then IVUS of LMCA to LID to make sure we have not damaged anything in the retrograde gear push and pull. Okay, done. Records. Okay, so we are doing IVUS from PLVB. So bifurcation is quite good. PDA opening is good. There is some plaque before bifurcation, but the overall lumen areas looks quite good. And we have dilated with 2.25 balloon here. We can see even the vessel size has grown now. So that's what happens, in a negatively remodeled vessel. When you do a little bit of ballooning, it expands. There is plaque here, but it's okay. I think, yeah, post balloon we have good areas. I think I would prefer, not to do anything to these areas. Okay. So overall stunt expansion is quite good. So I think there is no issues with stunt. Only thing is, we have to, yeah, enough. So we have not dilated this area. I'll also give a little bit dilatation to. So this area also I'll give a little bit of touch up with a 2.25 balloon. For me it looks okay. Yeah, next it's all negative remodeling vessel. So what is the distance from stunt start? I think it's just within 15 millimeters. Okay, dilate please. Yeah, okay. I've not dilated this area. Okay, keep it for 30 seconds. Out. Give me IVUS. Okay, so this is after stunting and post dilatation with 3 millimeter balloon. You can see the proximal reference increased to 7.6. We tried matching with the proximal vessel. Next. So this is around 6 mm square. Next. Yeah, 6. Next. So more than 6 mm square, and in areas it is 7 mm square. So yeah, B2 please. So post stunt, there was some lesion with, you can see 3.1 is the area. So that area we can see dilated with 2.25 mm balloon up to 10 atmospheres. And we are just doing IVUS of this area, now to make sure, we have not caused any dissection. So we are good with the stunt expansions, and we want to only see the distal, the vessel. IVUS live, please. So we want to see the distal vessel, after ballooning. So we shouldn't see any dissections. Flow limiting dissections. Pull back, please. We can see a good negative remodeling here of the vessel. I think this vessel will grow in size. The moment it grows, and your block area will come down drastically. That's what we are expecting. That is a yes. So there is a good lumen areas, luminal gain with the 2.25 balloon dilatation. You can stop. So we can see it is around 3.6 next. More than 3.5, and block areas are okay around 50 to 55. So I think this is the area you can see which we are concerned about. You can clearly see here, the vessel before our marker, before, how the size of the vessel is, and how the size of the vessel is, after B3. So there is a clear negative remodeling in the vessel. See, the moment, your B3 also becomes like the proximal vessel, your block area will go down. So we don't want to do anything here, bookmark. So, and uniformly the areas are more than 3.6 mm square. Bookmark here and show me the B1 area. What's the B1 area? So, and you can see the distal reference is only 3.3. So it's a good area. I don't want to do anything. So I'll close here. Okay, done. And do we really need to inject? I don't feel there is any need to inject here. So I'm just coming out. Okay, 035I please. We have used only 4 ml of injection. So for entire procedure, that's what happens, when you use a retrograde wire as a marker. So we can, close it with as least contrast as possible. But the key here is, the easy crossing of collateral. So when your effort for collateral crossing becomes more and more tougher, then you end up in the more and more issues. And here retrograde is only for antegrade guiding, so we have no intention to go with the retrograde wire crossing of CTO. It is only to facilitate my antegrade wiring without contrast. So that's the key. Come to RAO please. So we are now removing caravel. And in fact, you have seen, how the caravel and wire went in this case. The way they went into the RCA with effortlessly. So I have no suspicion on any damage, to the collateral or distal PDA. So yes, sorry, flush shell and. So that's the reason I don't want to even inject into my collateral. Flush, please. So we do IVUS from LID and you have to do IVUS across the septal, which we have crossed to make sure we have not caused any damage to the LID. And do it up to the ostial LMCA to see we have not caused any damage to ostial LMCA or the ostial LID. And most of the damage in retrograde happens, when you go across CTO with microcatheter and push microcatheter across CTO and externalize. So as in this case, we have not externalized. It's only retrograde marker technique. We generally don't cause much damage to antegrade. Yes, antegrade vessels. So the speckling is good. Overall LED flow is nice. And we can also see the vessel is quite small. Actually, it is looking like 2.25 vessel. Yeah, there is some blocking here, but it's okay. So not much, probably around 40% or 50% block. Yeah, this is a septal. We have not caused any damage around it. So yeah, this is a block proximal to the septal which we crossed. We have not damaged, we have not dissected the vessel. Yeah, we are almost coming to the hostel. Yes, this is LCX, Ramus and LCX. So this is LMCA. There is some blocking, but there are no dissections. There is no damage caused. So that's fine. We can also see just manual, please. I would always prefer to see up to hostile LM. So yes, because this is hostile LM, so we have not caused any damage. So I'm coming out. Out. So this is how we can, make sure about your retrograde vessels, whether you did any damage or not. Yeah, this is a minimal contrast CTO. I mean, we have done with 4 ml, RCA CTO opening in a patient with renal failure and creatinine of 3.7. So fine. Yeah. So thank you.